kleine Hunde. Und die meisten sind zu Fuß. Ich glaube, die habt das nicht viel.
Hereby I open this academic ceremony at Maastricht University. First of all, I like to welcome Mr. Alexander Gombert. He will defend his thesis entitled Application of New Specific Biomarkers for Organ Damage After Open and Endovascular Thoracic Abdominal Aortic Aneurysm Surgery as Model for More Accurate Perioperative Patients Surveillance. I would like to welcome all members of the degree committee, and in particular the three supervisors who are sitting just over me. Professor Jacobs, he is Professor of Surgery at Maastricht University and affiliated with the Maastricht University Medical Center. Professor Geert Willem Schuring, he is Professor of Vascular Surgery, also of Maastricht University and Maastricht University Medical Center. And Dr. Mees, he is Associate Professor of Vascular Surgery, also of Maastricht University and Maastricht UMC. I will introduce the 6 opponents later during the opposition, and I welcome the audience here in the aula and all the followers of the live stream. Mr. Gombert, may I invite you to give a summary of your thesis, and I wish you success in the coming hour.
Thank you so much.
Please go ahead. The floor is yours.
Thank you so much for the introductory words. Highly esteemed Pro-Rector, dear opponents, family and friends. It's a pleasure to be here today to present you my PhD defense of my thesis with the title Application of New Specific Biomarkers for Organ Damage After Open and Endovascular Thoracoabdominal Aortic Surgery as a model for more accurate perioperative patient surveillance. I would like to start my presentation with the following painting, The Wanderings of Odysseus, painted by Alfonso Silva from Sardinia, which what I like to call as a guide throughout my presentation today. So we're talking about biomarkers. So what are biomarkers? These are, per definition, naturally occurring molecules, genes, or characteristics by which a particular pathological or physiological process, disease, can be identified. Some examples from clinical fields, such as troponin, creatinine, and lactate. So, open TIA repair, open thoracoabdominal aortic aneurysm repair. This is more or less like this. So we're talking about a modern operation theater in the 21st century. In the middle, the involved vascular surgeon and his team, the scrub nurse. On the one side, the neurophysiologist taking care of this patient's spinal cord function. On the other side, the perfusionist taking care of the distal perfusion of the aorta and the selective perfusion. And of course, on the other side, the team of the anesthesiology taking care of patient's life in general. So this sophisticated surgical teamwork leading to results such as this, a procedure we did last week in case of an open repair of an infected aortic graft, replaced successfully, or a case in a Marfan patient with 32 years old receiving an open type 3 repair, or a procedure we did at least 2.5 years ago in case of a 16-year-old boy not suffering from a particular aneurysm but an aortic tissue involving the whole visceral segment. So as you see, a sophisticated teamwork leads to a very appropriate surgical aortic reconstruction. But there are cases when aortic surgery just feels like this. You know, everything gets out of control. And this is what we're talking here today and talking about. So what is the deal? We're talking about outcome and complications. And again, I would like to remind you of Odysseus and his fellows. So the first days after TAS surgery are of outstanding relevance for patients' outcome. There are a lot of organs to fail in the first days, such as kidneys, lung, intestine, spinal cord. And these organ complications predict morbidity and mortality for the patient. And sometimes you get the impression that it's like making a decision between Scylla and Charybdis in the first days after surgery. So what should we do? So early detection of organ failure is the topic of my thesis. So sometimes open TA repair hurts, so we need to keep an eye on the patient, like Odysseus did in case of Polyphemus. So how can we reduce the harm which has been done while we cured the patient's aortic disease? Of course, we need high-quality surgery and anesthesiology, appropriate surveillance on the ICU, and early detection of following complications after surgical treatment. But we've done it always that way. Maybe. But are we honestly focused enough to guarantee appropriate detection of these complications which had been mentioned before? Or should we check our sheep more intensively? So, and as I said, biomarkers. Can these solve all our problems? Or are these like sirens, saying that and doing a completely other thing? Are the findings of my presented studies really reliable? And should we believe the significant results I present you today and in my thesis and transfer these directly to our clinical routine? Or is it just too good to be true, or even a trap? In the second part of my talk, I would like to focus on the main findings of my papers which have been involved in this presentation and the thesis. So the first paper is focusing on the outcome of open TA repair. In the one paper, we focused in a multi-center study involving patients from Maastricht and Aachen, patients receiving complex aortic procedures involving the aortic arch, namely arch repair with frozen elephant trunk and elephant trunk repair, and afterwards open TA repair due to chronic or acute pathologies. And the other paper is a summary of open TA repair patients treated in Aachen, leading to at least 255 patients. So just to keep it very short. In the first paper and the second paper, we were able to assess a quite relevant morbidity and mortality rate. In the first paper, we had a mortality rate of 18%, based on the fact that we included acute and chronic pathologies. The rate of spinal cord ischemia was favorably low, but the rate of AKI was quite high. But after the surgery, in the mid and long term, we were able to assess a quite good survival rate and a very appropriate aortic reintervention and aortic-related mortality rate. The same is for open TA repair paper we published in 2021. We included all patients treated according to the same procedure we did in our department, and we were able to assess a mortality rate for the elective patients of 16%, which is high and relevant, and 35% in the emergency cases, leading to a total mortality rate of 20%. But still, in the mean follow-up of more than 3 years, the aortic-related reintervention rate was 2.8%, and the aortic-related mortality rate during total follow-up was 5%. So still a very favorable outcome in the long term. So I used these papers to underline the fact that although everything was done on a very high standard procedure with a very experienced surgeon, a surgical team, and a very experienced anesthesiological team, and the team on ICU too, there is enough space to improve patients' outcome after surgery. So biomarkers. At first, biomarkers for general outcome after open and endovascular TA repair, All biomarkers have been assessed under the same circumstances. So we assess biomarkers for at least 6 predefined time points, pre- and post-operatively. In case of zinc, the trace element, we also assessed the zinc levels 1 week after surgery. So these 3 biomarkers have been assessed, focusing on general outcome in patients. Bioardidimedaline and DPP3 are biomarkers, both are peptides, which are upregulated in the human body up to shear stress, inflammation, hypoxia, or in case of DPP3, in case of cell death, which can be found in the body due to trauma and due to aortic surgery by open and endovascular means. Zinc, the trace element, has been assessed focusing on the baseline value due to the fact that perioperatively the zinc values cannot be assessed appropriately because there's a shift of zinc to the liver in case of trauma and stress. So we couldn't assess an increase postoperatively accurately regarding zinc. So the outcome of these 3 papers, in a nutshell, bioRDM could be assessed to be related to in-hospital death and cardiogenic shock in the first time points after surgery, with a quite appropriate area under curve indicating an accurate test quality for in-hospital death and cardiogenic shock. DPP3 shows, to be honest, excellent predictive accuracy for in-hospital mortality and the development of any organ failure after surgery, starting at 12 hours after surgery, which is quite early regarding our knowledge. Furthermore, DPP3 is directly related to significantly increased levels of the SOFA score, the sequential organ failure score, which can be assessed on ICU for patients' survival, and other biomarkers such as procalcitonin, CRP, and interleukin-6. The zinc levels, when they are decreased at baseline, indicate increased mortality after surgery. The second round of biomarker papers focus on specifically AKI, acute kidney injury. We used the biomarkers UNGAL, which can be released from the kidneys, the tubules of the kidneys in case of stress, hypoxia, ischemia, SLPI, protease, which can be released also from different tissues of the body, such as mucosal surfaces of the pancreas, the lung and kidney in case of hypoxia and stress, and ribonuclease 1 and RNH1. These both are antimicrobial peptides which degrade extracellular RNA and can also be assumed as part of the host defense peptides. And last but not least, the biomarker combination TIM2 and EGFBP7, both are released in the human body in case of stress and have been related to organ failure such as AKI in different surgical and ICU scenarios. Once again, a brief summary of my papers, or our papers to be honest. UNGAN shows good diagnostic quality for the prediction AKI already at admission on ICU. So directly after surgery, UNGAL was very close related to AKI in the assessed patients. SLPI was surprisingly good regarding its predictive abilities for AKI, as in a multivariable and regression analysis, it still showed a significant correlation 12 hours after surgery with AKI. RNAS1, RNH1, and TIM2 and EGFBP7, both are related to AKI after surgery, not in a comparable way as it could be detected in case of SLPI, but still significantly increased levels could be observed after surgery in our cohorts of patients. So, just to summarize my presentation so far. Open TIA repair is related to a considerable rate of acute organ damage. The SCI rate seems favorable, but the rate of AKI is high. Biomarkers such as bioRDM and CPP3 are predictive for mortality and perioperative adverse events after open and endovascular TIA repair. And other biomarkers such as SLPI and others may deliver timely detection of postoperative AKI after open and endovascular TIA repair. A summary. Biomarkers for early detection after organ failure, such as AKI, may, after open-end endovascular surgery, may be useful and may help to improve patients' outcome. But be careful whose wine you drink. The results may be surprising. Thank you for your attention, please.
Thank you, Mr. Gombert, for your clear summary of your thesis. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Maasse. He is Professor of Cardiothoracic Surgery at Maastricht University. Professor Maasse.
Thank you, Mr. Prorector. Dear candidates, I would like to start this opposition by congratulating you and your supervisory team. I guess it must have been really difficult to study a cohort of patients that was collected, whose data were collected in more than 10 years. A lot of things must have changed in time. And reading your book was a real pleasure to learn more about these rare patients. Being the first, I would like to discuss with you a couple of overall issues. And the first is, it was not quite clear to me what the advantage is of being able to predict mortality as soon as possible after surgery. Could you explain that to me?
At least I will do my best. Thank you for the question, highly esteemed opponent. So this is an issue because throughout my papers we discussed where is the benefit for doing all this stuff, taking biomarkers, assessing the patient on the ICU more intensively. Is there a benefit such as improved outcome? And based on our studies, as I showed and I presented in my slides today, so far we cannot say that there is an improvement regarding patient survival if we assess them more accurately. But there are some publications focusing on exactly this particular issue because there are departments in Germany and worldwide trying to establish, for example, focusing on acute kidney injury, trying to establish a standard of early renal replacement therapy based on different parameters.
Yeah, but I would like to know your opinion about the mortality, specific to mortality, because the first chapters are dealing with that. What does it help the doctor in intensive care unit when he knows earlier that the patient will die? Yeah. And I want to consider also the fact that the mortality is already high. It's almost 20%. So you know already that 1 in 5 patients will die. How will it change your therapy?
Thank you. So I think everything is about raising. So people on ICU are always alert and focused on treating patients. But especially in the first days after surgery, which I try to underline in my slides, every hour counts. Everything is important. And especially in the first hours after surgery, there is sometimes a certain risk of delay during treatment of patients. And if you've got everything looks fine and laboratory findings, the need of catecholamines is stable and the patient looks okay. But if you've got one biomarker which is rather specific for adverse outcome, this may help you to get even more alert and to try to rethink the whole setting after surgery. So this biomarker can help you in the first days.
Might the opposite also be true, that when you know this patient is going to die, that you stop treatment or reduce treatment?
No. And maybe later on, of course not in the first days. It's all about improvement of patients' treatment in the first hours. And this is always the issue about biomarkers. So people say, this is why I used the slide, we did it always that way. And of course there are tools which help us to assess patient status on the ICU. And one have to think about if it's really reasonable and necessary to add something additionally, such as biomarker or a panel of biomarkers at least. But this is my very own opinion. I think it may be useful to assess at least some of these biomarkers, focusing on the biomarkers for mortality, on not only patients treated by open or endovascular TIA repair, but all patients on ICU. And maybe this may lead to a more timely efforts which can be done on ICU. Maybe based on the biomarker, you can start a different fluid scheme for treatment or start antibiotic treatment rather early. I'm not sure about that, because this is just a glimpse. All I did is just a very superficial glimpse, which may help to improve patients' outcome.
Okay, I understand. For the next question, I would like to go with you to page 48, and that's table 4. We have a group of young people involved in research with respect to the aorta, and sometimes I think they're really in love with the aorta. They consider the aorta the most important organ of the body. And perhaps it's the same with you, but then I was surprised that in this table, I think you are minimizing the role of the aorta by introducing the term aortic-related mortality. What do you mean by that? What is the exact definition?
Thank you for this question. So aortic-related mortality means mortality most likely related to aortic disease, such as secondary rupture of the aorta or failure of previous aortic treatment, such as open repair of endovascular repair. So I absolutely agree. This term is rather unspecific and vague, but it's at least it's popular in fields of vascular surgical research.
One more reason to ask you is the fact that when you look at the other categories, then you have cardiovascular, and that accounts for 25%.
Yeah.
But how do you know, this is the follow-up, the long-term follow-up, how do you know that the patient died of something cardiovascular and it was not aorta-related?
A very good point, especially as this is a retrospective study. There are certain flaws which have been faced in the discussion or the limitation section of this paper. And if we were able to claim that this is aortic-related mortality, which we was in at least 11 patients, we were sure that it was related to the aortic surgery or secondary rupture of a still existent aortic aneurysm. And cardiovascular summarize everything else, such as heart attack and stroke.
But you could find all the causes of that in these patients?
Not all of the causes, but in case of the aortic-related mortality, we were able to, yes.
Okay, great. One small last question. Yeah, I read that in this large population, this large cohort, there was in 50%, I guess, something like that, of the people, there was massive transfusion.
Yeah.
And I wondered, with all the measurements you did, how much was that of influence on the concentrations that were measured? Because the proteins are released into the circulation, and then you are measuring it, but the circulation is disturbed because of the massive transfusion, because there's no kidney function to remove things. So how reliable are the data then?
Focusing on the mass transfusion or on biomarker assessment postoperatively at all?
In general, because the circulation is the most disturbed element in these patients.
I couldn't agree more. So, but we're facing a problem. Now we are on a ship, and the ship is sinking, and we try to stop it from sinking. And of course, it would be very favorable to have a standardized, clear situation, only one parameter gets influenced. But this is the pity of clinical research. But of course, there is influence of mass transfusion, and there is the influence of all the things we did in the OR and afterwards. And yeah, as you said, and if you saw my slides, especially the last one, I don't want to be destructive, but I want to be honest. So I cannot discuss that there isn't an influence we cannot assess right now. But focusing on the initial issue we are facing, we try to improve patients' outcome as good as possible. Yeah. And even if there are parameters we cannot assess so far, I think this shouldn't lead to doing no research at all in field of clinical issues.
Okay, I'm happy with your answers. I give the word back to Mr. Prorector.
Thank you so much.
Thank you, Professor Maassen. The opposition will be continued by Professor Andy Baker. He is not here, but he is present online. And I think we can see him on the screen. Professor Baker is Professor of Vascular Biology at the University of Edinburgh in the United Kingdom, and he is also Professor of Cardiovascular Sciences here in Maastricht University. Professor Baker.
Thank you, Prorector, and dear candidate, congratulations. Very much enjoyed your presentation and reading your thesis, and congratulations also to your supervisors. Particularly congratulations to the number of chapters you have and the number of papers. This seems quite a very good output from your thesis. So I'm a non-clinical scientist, so I'm particularly interested in some of the molecules you're measuring. Sometimes we're interested in the biology, sometimes as biomarkers. In your beginning of your presentation, you mentioned the criteria for a biomarker and you used the word specific. I wondered whether you can just give me a little bit more on how a useful biomarker is in terms of the specificity. How do you quantify that? Could you start with that, please?
For the question, highly esteemed opponent. So just to make sure that I get you on, we would like me to talk about the specificity of the biomarkers we assessed throughout these studies, right?
Yeah, you're using them as you're developing them as a biomarker or using them as a biomarker. You know, what is the criteria to use as a biomarker? Not just what is specificity?
Thank you for the question. So again, a rather controversial issue while assessing biomarkers in any field of clinical research. So most of these biomarkers have been chosen because we were familiar with publication assessing these biomarkers in other fields of surgical treatment of patients on ICU. So we just tried to copy the findings of other researchers which have been done this publication in advance. For example, talking about SLPI, serine leukocyte peptidase inhibitor, this is a biomarker which has been assessed by a working group from Aachen, which is very familiar with the MIF, macrophage inhibiting factor constellation. And this is a part of the chain regulating the activity of MIF in the body. And based on one publication, which wasn't available at that time point when we started the research in fields of cardiac surgery, and we had a certain motivation to try to assess this biomarker in fields of aortic surgery as well, because of the high rate of complications we are faced to while treating these patients. And of course, the specificity, those biomarkers aren't biomarkers waiting for us to detect them as they are specific for aortic pathologies or aortic-related complications. But these are molecules and peptides which are released, at least if we are lucky enough, from the kidney, if we try to assess acute kidney injury, or they have been related to adverse outcome at all. For example, DPP3 and bioadrenaline are released upon endothelial damage, like shear stress. And these can be found, for example, in the endothelium of the aorta. So, of course, the specificity of these biomarkers is rather moderate, but still these can be used to assess postoperative organ failure. For example,
Okay. I mean, in just focusing on this nephro check, which I had a look at. So this is a combination of two biomarkers. So the test is the combination. So can you, I mean, these proteins are interesting, but presumably they're not specific to the kidney in terms of the injury. This is more general. But you're measuring acute kidney injury. Can you tell me a little bit about how these proteins you think are activated in acute injury in your surgical setting, and is that independent of the biology? So this is purely a biomarker and you don't care about the biology in the setting?
Of course not. So, but in fields of open aortic surgery, the impact of aortic cross-clamping and ischemia reperfusion is so overwhelming for the body that I think that the biological processes which are always active in the body are not stopped, but are completely involved and overwhelmed by the impact of the surgery. So that's why I think it's fair to say that these biomarkers can be used to assess pathological processes in fields of aortic surgery afterwards.
Okay. Why, I mean, in the setting of acute kidney injury or the surgical setting, that has a really traumatic effect. I mean, why is it these two proteins that are the key to the NephroCheck analysis? I mean, if you look at any studies that look at either circulating or within organ markers of disease, there are hundreds of changes. So what's the data to support the combination of these two?
Fields of, I think I cannot answer your question very satisfactorily for you, but we use NephroCheck based on the experience we generated by using TIMP and EGFBP7 in case of a previous study. And then I got familiar with NephroCheck as a bedside testing system, which makes it very feasible to check for AKI directly in ICU. And that was our particular reason to test this system, which we included, as you said, as a perspective into the study. Yeah. So I would say based on previous experience of other researchers, we tried this concept for our patients as well.
Okay. My last question really is about power calculations and your study. For example, I mean, you have quite a number of patients, and I understand how frequent, what patient population you have access to. But some of the comments in it, you looked at 90-day mortality in this in chapter 10. 90-day mortality was 9.6%, n equals 5. No statistical difference between the groups, between the two types of surgery. But presumably that's grossly underpowered. So I understand that you have those patients, but what sort of power would you need? Have you done power calculations to try and work out what you would need to answer the question properly?
We enjoy this question because we didn't do a power calculation, which is a pity, but based on our experience throughout the first years, we conducted this multi-center study focusing on NephroCheck, and we used a power calculation involving statisticians from Aachen and Frankfurt. And based on the reassessed likelihood for AKI in fields of open tear repair, the needed number of patients to get involved in the study was surprisingly low. And that's why, from the statistical point of view, it was very appropriate to include 50 patients to detect AKI in fields of open tear repair. So, no, we don't use power calculation for the first studies, but for the perspective regarding NephroCheck, we did.
Okay, thank you very much. And I'll hand the word back to the Prorector.
Thank you.
Thank you, Professor Baker. The opposition will be continued by Professor Heijmen. He is Professor of Cardiothoracic Surgery at Radboud University Medical Center in Nijmegen. Professor Heijmen.
Thank you very much, dear candidate. I also want to express my congratulations for your massive work describing it in your thesis. I've read it with great interest, and I think it's really important in this highly complex surgical group of patients to evaluate markers that can help you to early detect problems in the post or perioperative phase. But most of the impact is on the surgical invasiveness at the timing of the procedure, and that's why, as cardiac surgeon also involved in this open surgical procedure, I'm very interested in your chapter 3. Your chapter 3 focuses on a large cohort of patients over a 14-year time period, over 250 patients, which is a huge number. And you're describing a mortality of 16% in the elective group. Let's skip the emergency cases, but the elective group is 16%. And I think in all those cases, the setting should be ideal. In 2016, our center also evaluated over a longer time period, over 500 patients, more or less the same category of patients, and we noted a mortality in the elective setting of 10%, but I think the most striking difference is in the operative protocol, where you describe a 100% femoral bypass circuit for your aortic bypass. In our center, we use about 88% of left heart bypasses. Can you explain to me, and can you at first tell me, are you aware of the technique of left heart bypass, and can you explain to me the differences between left heart bypass and the use of this femoral extracorporeal circuit which you use?
Esteemed opponent, thank you for the question. I would like to start with the point that the mortality rate in the elective patients in this study was surprisingly high, and we had intensive discussions during the preparation of the manuscript, and we tried to assess the mortality of 16% by ourselves just to understand what happened in these patients. And what we saw, and which has been also underlined in the publication, was that there are some factors which are closely directly related to adverse outcomes such as mortality in these patients. So as I showed on my slides very briefly, the rate of previous aortic surgery was high, above 50%, and with at least 25% of patients suffering from Marfan syndrome, and I assume more than 60% of patients have been treated due to post-dissectional TAAs. And there's a specific impact which has been discussed in my discussion in the manuscript, is that all those patients are this is a kind of negative pre-selected cohort of patients, because all those patients are referred to our center in Germany from other university hospitals and larger hospitals in case of unfavorable anatomic conditions for endovascular repair. So, at least in our eyes, this is also an impact factor regarding the relevant mortality rate in this cohort of patients. For example, comparing our patients with the largest study focusing on outcome of open TIA repair published by Corselli et al., I think it was in 2017, assessing more than thousands of these procedures. These parameters, which I mentioned just before, where the likelihood for post-dissectional TIA repair and previous aortic surgery was much lower. And these are the conditions under which we understand the mortality is at least, we understand why the mortality was that high. And regarding the second aspect of your question, the comparison of the femoral cannulation and the left heart bypass, I'm familiar with the technique because Professor Jacobs has been performing this technique earlier, but regarding my experience in Aachen, we always rely on femoral cannulation. And of course, there may be arise the question, would it have been more appropriate to use left heart bypass under conditions to ensure antegraft perfusion, for example, of the visceral arteries? Is this related to better outcome? And as far as I'm aware, there's no study comparing those techniques in an appropriate way. And most of the, during surgery, we always assess the selective perfusion of the visceral vessels. And what we can say that at least the perfusion of the celiac trunk and the supramesenteric artery is above 400 milliliter per minute. So there is appropriate perfusion based on the femoral cannulation using the heart-lung machine. And so, of course, there may be an impact regarding this distal perfusion technique. I'm not aware of that. But based on the experience we have in our center, we're quite happy with the femoral distal aortic perfusion technique.
Yeah, I can understand you're talking about a very high-risk category of patients. I totally agree on that. But there's a clear difference between left heart bypass and extracorporeal circuit, FEM, with respect to the necessity of an extracorporeal lung, an artificial lung, which may have more impact on organ dysfunction postoperatively. But more importantly, maybe also the level of heparinization which you need. Can you elaborate a little bit more on that? Can it have an impact on your operative results?
And so heparinization is an issue, of course. As you see, the likelihood of mass transfusion intra and postoperatively is relevant. But by the end of procedure, we take our time regarding blood control, and it always starts with antagonization of the heparin completely. So at least we try to be as careful as possible to avoid any harm to the patient based on effects of heparinization. So I assume, from my point of view, that we take care as good as possible. But still, for example, there are papers from northern Italy, Milan, Professor Melisano, which assess this particular aspect using the ROTEM perioperatively. And they were able to assess that if there are any struggles regarding the anticoagulation after surgery, even if they took care of it in the OR, the outcome of patient is bad. And that's why, yes, there may be a negative impact of the need to heparinize our patients, of course.
Yeah, so if I understand you correctly, you don't see a clear impact of the technique you use with fem-fem extracorporeal circulation versus left heart bypass on your operative results. And that's good, I think, because we see more and more the use of this fem-fem bypass because it allows you also to take care of massive blood loss that can occur intraoperatively. Huh? And the other thing is what I noted is a clear difference in also the rate of perioperative dialysis. It's up to 29% in your cohort of patients. And I also see some differences in the operative protocols between the two centers. Is that you use custodial as nephroplegia or renal protection, where we are used to use Ringer's acetates with mannitol and prednisolone. Can you deliberate also on that? Because custodial, for me, is off-label use for nephroplegia, and it's meant to be for organ perfusion in transplantation surgery.
There is no time to elaborate on that. Time is up. We have to move on to the following opponent.
Sorry.
I'm very sorry. The time is up.
Thank you.
The next opponent is Professor van der Horst. He is Professor of Intensive Care at Maastricht University Medical Center. Professor van der Horst.
Thank you. Dear candidate, I also want to congratulate you and your team on this impressive thesis and all the other chapters that you wrote in manuscripts and so on. But I heard from Professor Jacobs that you already did some tremendous work in Aachen as well. I will focus, of course, on the postoperative trajectory, and I want to discuss with you something about mortality, the comorbidities, and then on your endpoints. The first question is, are the patients that are in Chapter 2 also partly involved in Chapter 3 and 4?
No.
No, they are a separate group.
Yeah,
okay.
Completely.
Thank you. Then my question is, could you explain the differences that in Chapter 2 there is almost no mortality after being in the hospital, but in Chapter 3 and 4 there is?
Yeah, so Chapter 2 we're talking about the frozen elephant trunk paper.
Yeah.
So, but the mortality in this paper is 18% in the
yeah, but
elephant.
after they died during the in-hospital stay, they go home, and then your mortality is very strikingly very low. But in Chapter 3 and 4, then your mortality rate is up to 20% after they leave the hospital. So can you explain the difference by selection of population in Chapter 2 compared to Chapter 3 to see what is the differences that they either die in hospital or not, and then they die in hospital and some of them also die afterwards?
Thank you for the question. So the increased mortality after open TAA repair is most likely, of course, the first impact is that it's a retrospective study assessing patients from 2 centers. And there is, of course, not regarding the mortality, because we're quite sure by the end of the day who is dead and who is not dead. But I don't have an appropriate explanation for that, but just by incidence, that the likelihood to die is, at least in my eyes, comparable if you receive previous aortic surgery and afterwards another aortic surgery. Yeah, and I would have expected at least an increased mortality in the paper focusing on frozen elephant trunk and elephant trunk if compared to elective open TAA repair patients. But it's not the way as things were, at least in our study.
I'm happy with that answer because I also didn't understand it. And if you don't, then it might be chance or something else, or that you even operated better on them. But we cannot know. Sure. Okay, and the other thing is diabetes as a comorbidity. So in the first population of 32 patients, it's over 30%, and in the other patients, it's as low as 9%. So in the big group, it's less than 10%. Is that because it was not known, or is it, again, the selection of patients?
I think both facts are true. So I think there are some parameters which could be easily assessed even in a large retrospective study. But as we're talking about nearby 10 more patients in the second study, I think this is more or less the realistic proportion of patients suffering from diabetes. And again, sorry for that, by incidence, in the first study, the rate of diabetes is surprisingly high.
Yeah, especially since they were young,
yeah,
and their BMI was relatively low. So maybe there is type 1 or something, but it struck me. Okay, now go in depth. Your endpoint. So in chapter 4, you discuss adrenomedullin, and you say it is predictive of shock.
Yeah.
4 patients had shock in that study, and that biomarker might be very good, but because if I didn't read it wrong, but the endpoint develops at day 7, 14, or twice at day 28.
Yeah.
Do you think a biomarker can be measured at day 1 and predict an acute myocardial infarction at day 28 and then the development of shock thereafter?
Yesterday evening, I was thinking about that question. I feared that anybody would ask it. So
Sorry.
we're here today, so I try my best. So no. So we, as you know, we did a study mainly focusing on outcome, and by incidence, we found that it was statistically seen. It was very significantly, but I always try to be as careful as possible, making some real-life conclusions based on these biomarker levels, especially in cases like that, because we are talking about a cohort of patients of less than 50 patients without power calculation, which has been mentioned before. It was prospectively done, but still, one has to be aware of the fact that this is maybe just by statistical incidence. So this has been discussed in the paper, and we try to be as honest as possible, because I fear that the external validity or reliability, so should we transfer these findings to a clinical routine, needs to be discussed.
Okay, and for the sake of time, my last question. If we would design together now, because I'm the colleague of Professor Marks, so we will design a prospective study after aortic surgery. Should we not see for quality of life as an endpoint instead of mortality?
Yeah, wonderful question. Because one of my paranymphs, the young man over there, just wrote a manuscript focusing on quality of life in fields of open TIA repair retrospectively, which is a pity, but it's a first start. And this should be done, because this is what we need to talk about, not just survival, but surviving as a human being who would like to survive at least a couple of years longer.
Super. I'm very satisfied with the answers, and give my word back to the pro-rector.
Thank you, Professor van der Horst. The next opponent is Professor Scheurers. He is Professor of Biochemistry of Vascular Calcification at Maastricht University. Professor Scheurers.
Thank you, Mr. Prorector. Dear candidate, also I want to congratulate you with this beautiful thesis, not only the cover, which you explained very well during your presentation, but also the content, based on 10 chapters, scientific chapters, and you actually could choose out of 90 plus papers. So I'm very, very jealous on that achievement, because as a basic scientist, we never reach these numbers. It is teamwork, because in the operation theater, of course, like you showed this beautiful picture with many people, also writing a thesis is teamwork, and I also want to congratulate, therefore, your promotion team. Now, I'm the odd one out today. I think I'm the biochemist between all the surgeons and medical doctors. So to get a little bit more familiar with you and what a surgeon and who a surgeon is, some small questions, and you only can answer or give one answer. Okay, you're doing your PhD here today in the Netherlands, you're working in Germany, so Germany or the Netherlands?
Italy.
You have to choose
from a professional point of view, Netherlands.
Aachen or Maastricht?
Maastricht, it's more like Italy.
Open surgery or endovascular surgery?
Oh, come on, this isn't fair. Michael is in the room.
I want to know you.
To be honest, I think the main part is, it's endovascular, but still,
one answer.
Okay, just endovascular, for God's sake.
Surgery or science?
It's surgery.
Biomarkers to predict if surgery is necessary, or biomarkers to predict organ damage after surgery?
Of course, the first one.
Okay, I'm happy that you say that. And then just an open question. Which was your favorite biomarker in all these 10 chapters?
Yeah, good question. It was SLPI, because it was rather unknown, and we had some good findings, but I think this is just a motivation for others to reassess our findings in other fields of patients on ICU or surgical scenarios. That's why I was very happy writing the findings.
Yeah. Now, you forced me to read your whole thesis because I'm the biochemist, so I had to read everything to get an understanding. Now, your thesis is about post-operative biomarkers to predict mortality. Now, in your discussion, chapter 12, page 213, you described that acute kidney injury was already described in the 50s of last century. So my first question, my real question is, if it was recognized more than 70 years ago, why are we debating this today still?
Very good question. What I first learned, but I can use more than one word to answer this question,
yes.
right? Okay. So what I first learned is that AKI was a completely underestimated complication following open and endovascular repair. And their attempts throughout the Vascular Surgical Society to do research focusing on that, and especially the long-term impact of this complication. And I think in the very first days of aortic surgery, when the pioneers of this, and we've got one of the second generation of pioneers in the room today, focused on keeping patient lives after surgery, I think the surgeons was satisfied if the patient was still breathing 7 days after surgery, not focusing on this pioneer, but the other one, the first generation. And the mortality was tremendously high. And so if the patient, to keep it very simple and profane, just don't pee for 2 weeks, so what? So he or she will die. And so there was no time and no intellectual space to consider these complications. And as things get more complex and the understanding of the body and the processes and fields of surgical repair increase, there is space to do research focusing on specific organ failure.
Yeah, fully agree. And in your title you also mention organ damage. Why the kidney, why not the lungs? For example, on page 105, table 1, 40% of your patients has COPD. Yeah. And COPD, it's the lungs, it's elastin, same as the vasculature. Yes. Why not this organ?
Yeah. This is a very good question because a lung is an extremely important organ, and it's even possible to assess this. But for example, in fields of open TA repair, there's always a certain lung damage which cannot be controlled as you do a thoracoabdominal. And he has one lung perfusion for at least, let's say, 1 hour. And of course, this is worthwhile to evaluate by biomarkers or everything else. But I focused on mainly the kidneys. Yeah. So, but I've got no appropriate scientific explanation for that.
Yeah. So you measure biomarkers after surgery. Now the question, coming back to biomarkers to predict whether or not surgery is necessary or not, I give you the hypothetical example. A 53, pretty handsome young guy needs operation, a male guy. And he is into science, so he reads a lot of literature. And he reads that if you have a diameter of your aorta of 6 centimeters, the annual risk is some 15%. Mm-hmm. However, the risk on death, on mortality in the normal population is 4%. So it increased risk of 10%. So 1 in 10 dies if you have a dilation of your aorta. In your population, 1 in 5 dies. Yeah. What would you advise this young person?
So of course, we need some time to discuss that aortic aneurysm is not comparable to the patients we treat in our cohort. If the patient suffers from a thoracoabdominal aortic aneurysm, there's still a very increased likelihood for complications. And most likely, if he received treatment by open means, if he's suffering from Marfan or any other kind of connective tissue disease, which disqualifies, makes endovascular treatment not possible, I think the likelihood to die is also around 5%, even if everything's done perfectly. So focusing on the previous question you asked for biomarkers assessing the risk for surgery, I think so far there is no good or specific biomarker available which can develop a pre-assessment for any cardiovascular risk after surgery at all, so far.
Yeah. So maybe I can help you there. So what we always are used to do is stay in the box. We do what we like, what we know. But if we look at the animal kingdom, then we have animals like marmots or bears that hibernate. They hibernate for several months. Hypoxia, no organ damage. Could we learn from the animal kingdom and finding the answer there?
Interesting question. Maybe it would be verifiable to increase our our knowledge regarding human pathology is looking at beers and whatever. But I think so. But for example, we are familiar with the likelihood of evolving aneurysm in case of apes, because we at least try to assess the aorta of chimpanzees, and we saw that there was never a kind of aortic aneurysm, never.
Yeah.
And so I think the findings from animal studies to fields of aortic surgery in human beings would be very favorable. It would be possible to conduct an animal study enabling further insights, but I think so far there is no appropriate model for this.
Yeah, I think your thesis learned me at least that we should collaborate and keep collaborating, because there is a lot of things to investigate. And with this, I'm happy with your answers and give the word back.
Thank you.
Thank you, Professor Scheurers. The opposition will be continued by Professor Mes. He is Professor of Neurophysiology at Maastricht University Medical Center. Professor Mes.
Well, thank you. Well, dear candidate, I also would like to congratulate you and your team of supervisors with the work you have been doing. Actually, it's largely on kidney problems. We heard about this. And I am as a neurologist, so I learned a lot when reading your thesis. After all, there is nothing like neuronephrology. I mean, this is all weird to me. So let's start the discussion on the differences between the kidneys and the spinal cord. To be, and as of course in the context of the TIA repair. What is the incidence of spinal cord ischemia and AKI in the patients you included in chapters 2 and 3?
So the clinical papers, as I said, the likelihood of developing spinal cord ischemia, our particular group of patients using the standard protocol for open TIA repair in Maastricht and Aachen was, at least in my eyes, favorably low. So I reported 2 cases of spinal cord ischemia in the frozen elephant trunk cohort. And
Okay. It was very low.
Yeah.
And what about AKI?
It was high. I think it was
Okay, so I always thought the central nervous system is the prima donna of the body. So I was pretty puzzled about this. What did the surgeons do intraoperatively to prevent AKI?
We listened to Paul. This is what we
No,
do.
to prevent AKI, not the spinal
okay,
cord.
okay,
So
sorry.
the spinal cord is okay, we do that, but what about the AKI?
So thank you for the question, highly esteemed opponent. So we used intraoperatively, selective perfusion of the kidneys by custodiol based on experience and papers published years before I started working in Aachen, which show that it's very appropriate to prevent AKI intraoperatively in aortic surgery. This is what we do. Yeah.
Okay, but
And of course, sorry, please let me.
it was
add.
obviously not really successful. I mean, the figures are just outright dramatic. And so I always thought, well, there is this renal artery, you put a catheter into it, and then you supply blood to that catheter, and everything should be fine. Don't the kidneys have any autoregulation or something with coping with low blood pressure? Does the kidney have that too, like the spinal cord?
Thank you for. Of course it have, but I think everything gets broke when we start the aortic reconstruction. So, and the impact of the kidney injury, which is a very good point, we're not quite sure about if it took place in the OR during the aortic reconstruction, or if the biggest impact is due to the reperfusion after opening the aortic perfusion again. This could be, because so far as I'm aware, there is no publication assessing the impact of the particular reperfusion of the kidneys after aortic reconstruction.
Yeah, but reperfusion, doesn't that mean that there has a too low perfusion before? Because if you don't have that, you cannot have reperfusion, right?
Right.
Okay, so there is a problem with the perfusion for some time, and I still do not get it, because there is also anesthesia, and at least for the central nervous system, if you have proper anesthesia, your metabolism goes down with 50%, which means also your blood need is lowered by 50%, which is very favorable for the surgical procedure. Does that apply for the kidneys too? Do they profit from anesthesia?
Yes, because right from the start, the colleagues of the anesthesiology team start trying to prevent the kidneys by using mannitol, for example, as intravenous infusion. And of course, there could be a discussion about if it would have been more appropriate to start a selective perfusion of the kidneys with whole blood. But based on research which have been done a couple of years ago, there was no advantage of whole blood perfusion of the kidneys compared to custodial. It was the other way around. So, of course, focusing on the high incidence of AKI, but just to explain that AKI not always means renal replacement therapy. This is one of the issues in the studies which have been conducted in the earlier years of aortic surgery, because we define AKI according to the KDIGO criteria. And grade 1 and 2 doesn't necessarily mean that there should be renal replacement therapy, because most of the patients reestablish renal function by themselves without doing any invasive therapy.
Okay, so it's not so serious after all.
It is serious after all, and we should be very sensitive regarding that, but I think there is not much we can improve in the OR, at least from my point of view.
Okay, so nevertheless, I think I got the slight suspicion that the mechanism for AKI is pretty different from spinal cord ischemia, and maybe it's not a consequence of decreased blood flow at all. Maybe. I think there is still some time. Yes, okay, I get a nod here. So to switch something else, and that might be even more interesting. So we discussed the kidneys, we discussed the spinal cord, but maybe there is something else that is even more important. And of course, as a neurologist, I think this is the brain. What is the incidence of stroke in endovascular procedures?
In general, the incidence of stroke in fields of TIA repair involving the descending aorta and the last part of the arch is favorably low.
Are you sure about that?
Excuse me?
Are you sure about that?
Regarding the literature and the experience in Maastricht, which is just much more experienced than we have, I think so. But if you're talking about endovascular procedures involving the aortic arch, the new generation of prostheses which are available, regardless if they are branch devices or fenestrated grafts, the incidence of a stroke is rather high.
Yeah. How do you know if the patient has a stroke? Is there an independent neurologist coming along and checking for the patient?
This is a very good question. I was involved in a couple of papers published in the European Journal, and this was my question. So they did a prospective study focusing on neurologic outcome, and there was no neurologist involved at all.
Does it make does it matter?
Yeah, I think so.
Yeah, it definitely matters.
Yeah.
You have figures in the literature that are up to 6-fold higher when a neurologist take a very good look at the patient. But maybe they hate the vascular surgeon, so they raise the figures. It can be even more disastrous if you perform a post-operative MRI.
Yeah, that's an issue. I asked the same question to a very good colleague from Germany. I will not tell you where he's working, but he told me that, to be honest, we just talk about relevant stroke. Relevant stroke means the patient had some clinical signs. We're not talking about images. And he said the incidence in fields of aortic arch repairs, let's say 20%.
Okay. I'm satisfied with the discussion, and I hand back the word to the prorector.
Mr. Gombert, as you have seen and heard, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis, and in particular, the quality of your defense, and please await our return.
Thank you so much.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. sure you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like, my goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like, my goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like, my goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Mr. Gombert, the committee here present and also online has assessed the quality of your thesis, and in particular the quality of your defense. And in view of this positive verdict and taking into account your previous qualifications, the committee has decided to grant you the degree of doctor. Professor Jacobs is authorized to confer upon you this academic distinction in accordance with Dutch University custom and law. And I invite your supervisor now to take the floor. Professor Jacobs.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I do.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Alexander Gombert, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dear Privatdozent Alexander Gombert in Germany, aber ab jetzt auch PhD in the rest of the world. Jetzt können wir in Deutsch einige Worte weiterreden. Also, lieber Alex, Familie, Freunde, herzlichen Glückwunsch an diesen Montagnachmittag, 27. März. Wir erlebten heute eine großartige akademische Sitzung mit einem hervorragenden Ergebnis, zusammen mit deiner Familie und Freunden. Bemerkenswert ist, dass es hier in Maastricht stattfindet, die Stadt, wo die Europäische Union gegründet wurde. Das war aber in 1991 und da warst du erst 8 Jahre jung. Für dich ist Aachen deine Stadt. Du hast Medizin studiert in Aachen, deine Approbation in 2013 erzielt und im Rekordtempo eine Stelle zur Weiterbildung in unserer Klinik für Gefäßchirurgie bekommen. Es war uns alle schon sehr schnell klar, dass wir es mit einem sehr ambitionierten High Potential zu tun hatten. Von Anfang an hattest du Interesse in basaler und klinischer Forschung und das Wort Habilitation fiel schon in 2014. Während der folgenden Jahre etablierte sich eine sehr große Herausforderung, tatsächlich eine Habilitationsarbeit zustande zu bringen und eine Familie mit 3 Kindern zu gründen und auch zu organisieren und das zu kombinieren. Aber offensichtlich ist es dir und deiner Frau Ricarda gelungen, diese Herausforderung in die Realität und mit Erfolg umzusetzen. Mit 3 wunderschönen Kindern, Margreta, Leonard und Theodor. Und eine Habilitation in 2019 zu erreichen. Von Doktor zum Privatdozent. Chapeau. Aber das reichte nicht. Eine Woche später kam schon die erste Bemerkung, dass der Titel Privatdozent nur in deutschsprachigen Ländern eine Bedeutung hat. Und das war für PD Gombert mit internationalen Ambitionen natürlich keine Option. Also lag in der gleichen Woche eine Frage auf meinem Schreibtisch, wie wir das lösen könnten. Wie gesagt, du hattest klare Ambitionen auf der akademischen Ebene, dich international zu profilieren, und dafür war eine PhD-Titel die einzige und die beste Lösung. Aber so einfach war es natürlich nicht. Vor allem, weil die Publikationen, die in der Habilitationsarbeit aufgenommen waren, nicht in einer PhD-Arbeit dupliziert werden dürften. Und damit stellte sich die nächste Herausforderung, und es wurden neue Studien entwickelt und viele Manuskripte dazu geschrieben. Und 3 Jahre später stehen wir hier in Maastricht und da hast du diese PhD-Urkunde in deine Hände. Wirklich, wirklich außergewöhnlich und du verdienst größte Komplimente. Vom Arzt zum Doktor, vom Doktor zu PD und vom PD heute zum PhD. Deine Familie und dir selbst kann mit Recht stolz auf dich sein. Gratuliere.
Esteemed Dr. Gombert, dear Alexander, it's my great pleasure to congratulate you with the doctorate that you have acquired today. And I do that also on behalf of the Board of Deans of Maastricht University. And maybe I may share some impressions of the committee with you. We have seen a very clear presentation, I think also for lay people. And your thesis we have considered as very good, a high standard of the content, and it was really a complicated subject you studied. And it has been published in many publications in good journals. In the opposition, we had really a broad range of questions, and we think you answered these questions in an excellent way. I might say honest, open, and clear. And so we appreciate the high quality of your defense, and we also noticed that you have shown that you're very knowledgeable of the scientific field that you have studied. And I want to congratulate not only you, but also your 3 supervisors. Dr. Bees, Professor Schuring, and Professor Jacobs, congratulations with the result that we have seen in the form of a very good thesis and an excellent defense. And of course, and I do that in English, I would like to include in my congratulations also your wife and children and other members of your family. And also, of course, also your colleagues, friends, and the people that have followed the live stream and are present here in the aula. Congratulations. I would also like to thank the members of the committee, not only this committee, this degree committee, but also the thesis assessment committee. Thank you very much for your input, and in particular, I would like to thank in particular the external members of both committees, and I would like to say that Maastricht University appreciates your input. I think it's now time to invite the 2 online members to congratulate the young doctor. May I invite Professor Baker as the first opponent?
Sure, yeah. Well, congratulations. I thought very rarely do I see a thesis. I've done them all over Europe with such a large amount of data and publications in. So there's obviously some teamwork, but you obviously led quite a lot of it as well. So the thesis and the outputs are terrific. And the defense was also terrific. I enjoyed trying to understand the area and what you're trying to do. And I wish you great success in your future career. So well done.
Professor Heijmen?
Yeah, Dr. Gombert, dear Alexander, also my congratulations for your doctorate, also for your supporting team and your family. It's a great effort. It's great to see a practicing vascular surgeon having so much knowledge and interest in basic science. Keep up the good work, and hopefully we can collaborate together also in the future on this very highly complex surgical group of patients. Enjoy the day.
Before I close the ceremony, I would like to ask the people here in the aula to stay here. Meantime, we will have a picture taken of the committee and you in the middle, and with the two opponents still on the screen. And then after that, we will make a picture as well, a second picture in the stairs in the hall. So please, may I invite you to come forward with your and the members of the committee.